Firstly, thank you very much to CUHK and a very kind invitation from Samuel, Jeremy, and Peter to give a talk on cardio-oncology. It's really a great honor to be here among very esteemed speakers, and congratulations to the organizers for a fantastic program. Very quickly, these are my disclosures, and in particular, this talk is not supported by Ferring. I don't profess to be an expert in this area, but I will share some insights on cardio-oncology, starting first with the intensification in advanced prostate cancer, which we have heard a lot this morning, and then discuss the impact on how hormonal manipulation impacts cardiovascular health. And lastly, discuss some mitigation strategies that we can consider in our holistic management of metastatic prostate cancer patients. So indeed, few areas in oncology have seen as much progress in recent years as metastatic prostate cancer. The introduction of the next generation AR pathway inhibitors and the concept of treatment intensification has resulted in patients living longer. Along with overall survival benefits, the lifetime exposure to ADT is also increasing. Now, ADT being the basic tenets of treating metastatic prostate cancer has been diligently included in all of the landmark phase 3 trials that we see, and will continue to do so for many of the ongoing and future trials looking at novel combinations. Now, the heart of the matter remains. Most men with high-risk localized de novo metastatic or recurring cancers will be exposed to ADT, which has been shown to increase cardiovascular events. Now, this includes earlier onset and an increase in fatal myocardial infarctions and even sudden cardiac deaths from a large SEER Medicare analysis. In fact, the figures are alarming. Up to 90% of men receiving ADT in the HERO trial have baseline risk factors or cardiovascular disease. Now, this increased risk of cardiovascular events among men treated with leuprolide is noteworthy because death from cardiovascular causes is now the leading cause of death in prostate cancer patients, and almost accounts for close to a third of deaths, as shown in these two large population-based studies in Sweden and in the US. The profound hypogonadism by ADT is associated with a wide variety of adverse health consequences in various domains, ranging from sarcopenia and osteopenia to dyslipidemia and glucose intolerance. But how exactly does hormonal treatment impact cardiovascular health? And we know that low testosterone levels result in various cardiometabolic changes that occur within 12 to 24 weeks of ADT initiation. And diving deeper into the mechanisms of action, we see that low testosterone levels are associated with longer heart rate corrected QT intervals, and prolonged QT intervals can result in an increased ventricular arrhythmia incidence and subsequent sudden cardiac death. The majority of preclinical studies have found testosterone to have vasodilatory effects, a process that likely involves the downregulation of calcium channels and the upregulation of potassium channels. Now, further, testosterone has also been implicated in cardiac contractility. So, castration hence decreases vasodilation and cardiac contractility. Some observational studies have reported inverse correlations between testosterone and intima media thickness, which is actually a surrogate marker for atherosclerosis. Now, although there's a lack of RCTs reporting directly on atherosclerosis, some have reported on carotid intima media thickness and plaque calcification, leading to the phenomenon of arterial stiffness and accelerated atherosclerosis. The mechanisms involved in atherosclerotic plaque destabilization and rupture have been extensively studied. And we know that T cells express GnRH receptors, and the activation of these receptors have been shown to stimulate T cell expansion and differentiation into the T1 helper cell phenotype. And these pro-inflammatory T1 helper cells are the dominant T cells in atherosclerotic plaques and help to activate macrophages, which infiltrate the plaques and release proteases that erode that thin cap of connective tissue covering the plaque, ultimately resulting in plaque rupture. Now, implicated mechanisms that underlie the metabolic and atherothrombotic changes of ADT include the loss of androgen-mediated inhibition of stem cell differentiation into adipocytes, a decrease in lipolysis, and an increase of cytokines, creating an inflammatory milieu that may contribute to both insulin resistance and atherogenesis. The radical PC is a large prospective cohort study that includes standardized assessment of cardiovascular risk factors in patients with prostate cancer treated with ADT. Now, what they found in close to 3,000 consecutive men with prostate cancer from over 24 sites is that nearly all patients had at least one uncontrolled modifiable cardiovascular risk factor, and more than half had 3 or more uncontrolled modifiable risk factors. And this was very similar in the findings of HERO trial as mentioned earlier. Another critical and concerning finding of this paper was that poor control of these cardiovascular risk factors occurred regardless of ADT use or a history of cardiovascular disease. So we need no more convincing of the detrimental impact on cardiovascular health that ADT brings, nor of the magnitude of the baseline cardiovascular risk among our patients. But what are some of the strategies that we can adopt to mitigate the cardiovascular risks? Here I've broken it down to 3 categories: drug-related strategies, optimization of cardiac surveillance and care, and lastly, patient lifestyle factors. Now, with regards to hormonal strategies, the first and foremost comes the decision on GnRH antagonists versus agonists, and there's strong data to support the use of antagonists in this respect. Pooled data from 6 phase 3 prospective RCTs comparing efficacy of GnRH agonists versus an antagonist showed that for men with pre-existing cardiovascular disease at baseline, the use of an antagonist resulted in significantly fewer cardiac events or deaths, corresponding to a 56% lower risk of cardiac events or death during the initial year of treatment. The absolute risk reduction during the first year of treatment was 8.2%, which translated to a number needed to treat of just 12. In the HERO trial, relugolix, as we all know is oral antagonist, was associated with a significant 54% reduction in the risk of major cardiovascular events compared to the agonist leuprolide. Now, this is remarkably similar to the effect size as we have seen for dagarelix. This benefit appears to be the most significant in patients with prior cardiac disease, with a 5.8-fold decrease in the odds of a cardiac event compared to just 1.5-fold in those without a history of cardio disease. At this point in time, I must congratulate CUHK, Jeremy and team for being early contributors to the body of knowledge on this topic of cardio-oncology, with this paper published almost a decade ago when there was still relative lack of awareness in cardio-oncology. The era of combination therapy has seen OS benefits, which comes at the expense of long-term toxicity. So what about curtailing ADT in combination therapy? Now, controversy has surrounded continuous versus intermittent ADT for more than a decade. The PR7 trial in 2012 reported that intermittent ADT was non-inferior to continuous in patients with biochemical recurrence following primary or salvage RT for localized disease, but in contrast, the SWOG 9346 trial failed to demonstrate that non-inferiority, however, in a cohort of metastatic hormone-sensitive prostate cancer, possibly because of insufficient events in the experimental arm. But the question remains, with the pressing need to balance treatment toxicities, can we de-escalate treatment in some patients to mitigate toxicity while maintaining efficacy? There are naturally many facets to this conversation, and I'll approach the various points of view. Firstly, the use of PSA, as has been extensively discussed, is a key consideration in identifying patients for de-escalation approaches and to define what we call exceptional responders. In the post-hoc analysis of SWOG 9346, exploring the prognostic significance of PSA levels 7 months after random assignment, we see the median overall survival for various PSA responders are as shown in the survival curve on the right. These data suggest that a cheap, convenient biomarker such as PSA, less than 0.2, is a more appropriate threshold for defining exceptional responders, most suitable for a de-escalation strategy. Subsequent analysis from the CHARTED and TITAN trials with docetaxel and apalutamide respectively also confirm the prognostic significance of achieving undetectable PSA 6 to 7 months after initiation of treatment. Now, interestingly, the difference we see between those who achieve PSA less than 0.2 versus those above 4 is actually bigger than the difference that we see between low and high volume disease. as shown in this Taiwanese study on the left here, where OS difference between high and low was just 38 months, which is much less than what is shown in the SWOG 9346 trial. And also when we look at the OS survival of control groups who receive only ADT in Chartered and GTUC 15, and again you can see that the survival difference associated with disease volume is smaller when compared to that seen in groups stratified by PSA response. So in the same vein, consideration of disease characteristics may also be a critical factor in making decisions about treatment de-escalation. And we already know that the disease volume, high versus low, and the disease state, synchronous versus metachronous, are significant prognostic biomarkers in MHSPC. So therefore, patients with a low volume or metachronous disease may be more suitable for de-escalation approaches. Next, patient factors such as age, comorbidity, and anticipated toxicities from therapy may also play a role in de-escalating the treatment. Now, it would seem appropriate that older patients, those with life-limiting comorbidities, and those experiencing major toxicity will be appropriate candidates to start with. However, there's currently a lack of robust data on how patient factors may influence these decisions. Ultimately, a shared decision-making framework with patients is critical and crucial. What we do know is that, as seen in the FIN prostate study, that looked at the quality of life and adverse effects amongst patients who had intermittent versus continuous ADT, there was clear improvement in physical capacity and sexuality during castration breaks, among other domains. So, biomarkers may also play a key role in addressing this clinical conundrum. Is there a way to select patients who may only require monotherapy? Now, SPOC mutations, as mentioned by Darren earlier, are predictive of a very highly favorable response to ADT and AR pathway inhibitors compared with docetaxel. Other parameters or biomarkers we looked at are like genotypes of HSD3B1. These variants are validated to predict for clinical outcomes in patients on ADT. Radiological response with molecular imaging such as PSMA PET may be another tool that can be used to identify exceptional responders and warrants further exploration. For example, we can postulate that patients with no or minimal disease on PSMA PET after a period of systemic treatment may be ideal candidates for de-escalation approaches. So ongoing and future clinical trials will inform us further, starting with ADREAM, which is designed to seize both ADT and AR pathway inhibitors after 18 to 24 months of treatment in those with very favorable PSA response of less than 0.2. Now, the primary endpoint in this trial is to assess the percentage of patients who remain treatment-free at 18 months. Another trial in this space is the de-escalate trial, a randomized pragmatic trial revisiting the concept of intermittent ADT in patients, again, with excellent response with PSA of less than 0.2 after 6 to 12 months of doublet hormonal therapy. The PREDICT-RT is another international phase 3 cooperative group trial looking at using low decipher score, less than 0.85 in high-risk prostate cancer patients to test a shorter duration of ADT. And lastly, what is the role of metastasis-directed therapy to consolidate responses before de-escalation? We know that data is emerging for MDT in the setting of oligometastatic prostate cancer and the purported benefits of delaying systemic treatment. Now, this is beyond the scope of my talk, and so I won't cover the data, but this is definitely food for thought. Still on drug-related strategies, AR pathway inhibitors dramatically attenuate testosterone signaling and even more profoundly than ADT, compounding our cardiovascular risk. So this table, taken from the European Society of Cardiology guidelines, summarizes the various cardiovascular adverse effects, and you can appreciate how significant the impact is for apalutamide, enzalutamide, and abiraterone, as highlighted in yellow. In a meta-analysis by Lacovalli, including 6 phase 2 and 3 trials testing enzalutamide and abiraterone in MCRPC patients, the addition of AR pathway inhibitors to ADT resulted in an increase in cardiovascular events of 36% compared with ADT alone. This was not seen for enzalutamide. These results were confirmed again by the meta-analysis by Moreira, as seen here in this forest plot. So multiple community-based studies have reported a high prevalence of conventional cardiovascular risk factors among cancer survivors. And when multiple cardiovascular risk factors coexist, they actually have an additive effect to the global cardiovascular risk for the patient. So consequently, a cardiovascular risk assessment should ideally be performed. Although prospective validation is needed, the ESC guidelines support the use of HFA, International Cardio-Oncology Society Baseline Risk Stratification Score, which essentially looks at various domains, as you can see here, starting from demographics to cardiovascular risk to previous cardiotoxic therapies. While it is clear that men receiving ADT should be monitored closely, there are currently no standardized guidelines regarding cardiovascular monitoring for this population, and this is actually an urgent, pressing unmet need. A recent scientific statement from American Heart Association recommends monitoring for reversible cardiovascular risk factors and the development of metabolic syndrome every 3 months. The ABCD algorithm has been conceived in 2016 and can be used to systematically address reversible risk factors and is recommended by the American Heart Association and the NCCN for patients receiving hormonal therapies. And this can serve as a framework for us to check off the measures we can adopt to improve cardiac surveillance and health for our patients. Purposeful engagement in multi-D care between oncologists, urologists, and cardiologists is critical, and various risk calculators have been developed, although none are validated and developed for Asian population. So in my practice, I routinely monitor cardiometabolic risk factors at baseline, such as fasting glucose, lipids, HbA1c, and bone health. I think in the interest of time, I'll quickly fly through the next few slides. Lastly, we consider what patients can do for themselves. Exercise therapy has been shown to have significant improvements in exercise capacity, inflammatory markers, but it is still unclear whether these results can be translated to a reduced risk of cardiovascular morbidity and mortality. And these are some of the ongoing trials looking to answer this question, such as PRO trial and the interval gap 4.
Hi everyone. Today,
these are some of the educational videos that I've conceived and developed over at my unit, hoping to increase the awareness and empower patients to do more in this aspect. So these would include increasing awareness of the side effects of ADT, as well as encouraging them to do self-directed exercise. And lastly, I think recently I've submitted a collaborative grant. Our unit has submitted a collaborative grant looking to assess using AI and multimodal machine and deep learning to look at large data sets to see if we can create a risk score specifically for this cohort of patients. And this would delve into digital biomarkers, genomic biomarkers, and clinical biomarkers as well. I would like to end off by sharing some key messages. I think the survival of advanced prostate cancer patients is increasing, and the increased exposure of ADT should prompt us to focus on long-term toxicities as part of holistic management. And it's crucial to consider cardiovascular impact, especially in a geriatric population. Cardiovascular risk factors are known to be very common among our patients, and a close collaboration with a cardiologist will help to optimize their risk factors. As treating urologists, we need to actively consider mitigation strategies in the choice of our ADT as well as AR pathway inhibitors. And future trials are still needed and will inform safety, feasibility, and the efficacy of various de-escalation strategies. With that, thank you.